Вы в эфире.
Very good evening, ladies and gentlemen. Thank you for joining us today. Добрый вечер, дамы и господа. Спасибо, что присоединились к нам сегодня.
Good evening, ladies and gentlemen. Thank you for being with us today.
In Russia and former CIS countries and Ukraine. Меня зовут Платонова Елена. Я являюсь генеральным менеджером CENTIS в России, в странах.
I am the general manager of CENTIS in the CIS countries and Ukraine.
International webinar and give a floor to founder and president of CENTIS Pharma, Deepak Bari, for a welcome speech. Сегодня мне выпала честь поприветствовать вас всех на втором международном вебинаре CENTIS, предоставить слово основателю и президенту компании CENTIS Pharma Deepak Bari для приветственного слова. Please, Deepak.
Dr. Bari, please.
Friends, let me express my warmest greetings and welcome all our friends from Russia, India, Kazakhstan, Kyrgyzstan, Uzbekistan, and some friends from US and Europe also. 117 years ago, on this very day, the Wright brothers made their first flight of the aircraft which they invented. Today, we have our second flight because we had a very successful first international webinar a few months ago, and therefore it inspired us to have this second webinar for the interest of all our friends and partners. Science always marches on. There are many studies, new methods, new developments, and we would like to share all these developments with you. Today's panel discussions between the participants, leading key opinion leaders in ophthalmology, will allow us to share best practices, receive invaluable recommendations, and to get solutions for practical day-to-day issues. I wish everyone a very fruitful participation. Дорогие друзья, меня всегда очень приятно.
Dear friends, it is always a pleasure to meet with you and to talk to you. We have had many years of experience with you and with your country. I hope that today we'll have very interesting presentations and a good webinar. Thank you so much.
I would now request our Executive Director of Russia, Mr. Ruslan Kamalov, to say a few words.
Thank you very much, Deepak. Good evening, dear colleagues. On behalf of CENTIS Russia, let me welcome you on our event, and thank you very much for attending CENTIS second international webinar. We at CENTIS very appreciate it that you find time to be with us, and we find it to be very important that we take this opportunity to meet, and in this hectic time, we exchange on information and also exchange on ideas. But what is also very important, that we interact with each other. Yes, we do it in this digital format, but still in very warm and also smart, but what is most important, in very friendly atmosphere. So I wish all of us some good luck, but also passion, but also interesting and inspiring communication today. Дорогие коллеги, от лица CENTIS,
dear colleagues, on behalf of CENTIS Russia, I'd like to welcome you here at the second International CENTIS webinar. Thank you for joining in at this hectic time and participate in our international conference. I grabbed this opportunity and to thank you cordially for the work you are doing on a daily basis, because we know that There are a lot of risks accompanying your job, and naturally, it's very important to maintain the health of our citizens, and we're very grateful for fighting COVID-19 and the contribution you provide for fighting this coronavirus epidemic. I'm glad that we have the opportunity right now to maintain cooperation, but we have our giant agenda. In this case, the interaction between healthcare professionals and manufacturers has become a very relevant issue. I'd like to wish you every success today at this webinar, and I hope that this interaction will be filled with positive emotions. Right now, I'd like to introduce the moderator of our today's session, who is head of the therapeutic department of the Fedorov Eye Microsurgery Center, is a specialist in cornea, who is chairman of the European Ophthalmological Society, an expert in the field of ophthalmology, a great doctor and scientist, Dmitry Maychuk. Dmitry, thank you very much for agreeing to be the moderator of our today's agenda. I'd like to give you the floor, and I'd like to wish you every success in our today's endeavors. Thank you.
Ruslan, thank you very much for this opportunity. Dear doctor, dear colleagues, I'm really happy to see you. Unfortunately, we cannot meet again because of this COVID-19 problems. But it's great that at one time we could speak to doctors from so many countries, from India, which I really love. And I think this is something which inspires us for our meeting today and bring us health and the chance of meeting again. I'm really glad to hear doctors and to see doctors from Ukraine, from Kazakhstan. I've been there many times and I love the people, I love the country. And hopefully in a year we'll be able to meet soon again. I want to thank for this opportunity for this webinar, of course, our colleagues from Sentis Pharma, because I really think that they're making a huge amount of work of helping not only doctors, but helping people with all these pharmaceutical devices which they provide to us. Without them, we will not be able to treat patients, we will not be able to really exchange knowledge. So thanks for Deepak Bari, and thanks for all the team from Sentis. We will start today our meeting, and we will be speaking about COVID-19. Hopefully, we'll be able to fight it soon, and this way we'll be able to meet again. And the first author of the presentation, whom I want to introduce, may I ask to put a slide, introduction slide for Dr. Yelena Yani? Well, since it's not here, yes, thank you. We love Dr. Yelena Yani. She is very famous in Russia. She is one of the most famous ophthalmologists, mostly because she is not only because she's a co-chairman of the Russian Red Eye Advisory Board, not only because she is an author of 147 something publications, not only because she is a very nice lady, but mostly because she is the head of Department of Infectious and Allergic Eye Diseases. And this is the biggest, the main department which deals with ocular surface inflammation. So she is one of the most well-known by her knowledge and by her team. So Dr. Elena, I welcome you with your speech.
Thank you so much, Dmitry, for these wonderful words. Thank you for this wonderful introduction. I'd like to thank Sentis Pharma for letting me participate in your webinar. As for the title of my presentation, it's a compilation of the experience we have gained during the pandemic. These are specific cases that we encountered in our practice when we had the lockdown, when we had a lot of severe patients, and we did not have a clear understanding what the coronavirus is all about. We could not manage well with our patients. Now the situation is coming back to normal, and I'd like to present the experience of my work in this context. Well, eye damage in COVID-19 patients. The causative agent, as you know, is a virus of the Coronaviridae family. Earlier, acute respiratory syndrome caused coronavirus type 1. They both have receptor binding domains, have similar epidemic features, and cause similar systemic pathological changes. As for SARS-CoV-2, it's a single-stranded RNA beta coronavirus without a lipid envelope. The genome is 96.2% identical to the COVID genome of the natural host bat. It is acquired pathogenicity for humans as a result of multiple mutations and subsequent infection of the immediate host. As for the COVID-19 epidemiology globally and in Russia, it is quite threatening. You can see the data on the slide. That's for December 17. This morning, you can see a large number of infected people. You can see a high number of deaths. As for ophthalmological manifestations, they occur not only in case of COVID-19, they also occur in case of adenoviral infection. In more than 82% of cases, we have ophthalmic manifestations. Rotavirus infection is accompanied by affecting our eyes in more than 39% of cases. In case of other coronaviruses, such as MERS and SARS, no ocular manifestations were reported. But this is due to the fact that the number of people who contracted the virus was relatively small, 2,500 and 8,500, as compared to the data presented on the previous slide. That's a very small sampling. Other viruses, such as Ebola and Zika, cause both acute and chronic eye diseases, conjunctivitis and anterior uveitis. As for COVID-19 transmission routes, there are two major transmission routes, airborne and contact route. Bringing to bear all these factors, the Ministry of Health of the Russian Federation came up with interim guidelines for prevention, diagnosis, and treatment of the new coronavirus infection. Bringing to bear the transmission routes, the eye surface is a potential target tissue for SARS-CoV-2 penetration. As for lab diagnostics, well, determination of RNA SARS-CoV-2 is done by using reverse transcription polymerase chain reaction. RT-PCR is a highly specific test. The information content is close to 100%. The sero-diagnosis of COVID-19 is done on the basis of determining the IgG, IgM antibodies to SARS-CoV-2 in blood using ELISA. Well, as for our experience, we have decided to divide ophthalmological manifestations due to COVID-19 into specific groups. Group number 1, that's early manifestations of the disease. These are the clinical symptoms that appear at the very start of the onset of the disease. Then there are manifestations in the acute stage, and here there are three subgroups: pathogenetic manifestations, ophthalmological manifestations due to the treatment conducted, and defects of care. And I will talk about this in detail later, plus late manifestations of the disease. That's the group of diseases which will have to be studied in the future. As for the early ophthalmological manifestations in COVID-19, these are different kinds of conjunctivitis. These were the first cases described in the literature. These were the first pathological changes when doctors paid attention to that. In all countries, since the conjunctivitis is not very widespread, only in 0.9% to 8% of cases, conjunctivitis develops as a result of the introduction of the SARS-CoV-2 viral agent. By the nature of the cause, this is acute conjunctivitis with the predominantly affecting both eyes. The clinical picture is characterized by edema of the conjunctiva, often localized in the transitional fold in the region of the bulbar conjunctiva. SARS-CoV-2 has a pronounced epitheliotropy. There is destruction of epithelial cells, vacuolization of the cytoplasm nuclei, fragmentation of chromatin nuclei, and accumulation of acid phosphatase takes place in this case. Here is the clinical picture of viral conjunctivitis in COVID-19. It has no specificity. The diagnosis is made on the basis of anamnestic and epidemiological data, physical examination by microscopy, and according to lab tests data. Since viral conjunctivitis is not among 5 major manifestations of COVID-19, it doesn't mean that we should not pay attention to it. As for viral conjunctivitis, well, we should pay attention to general symptoms such as respiratory tract damage, catharsis, general weakness, increased body temperature, headache, loss of smell, and gastrointestinal tract damage. There should be a combination of 2 or 3 clinical signs that's a pathognomonic for COVID-19. As for treatment of conjunctivitis in case of COVID-19, again, bringing to bear the pathogenetic mechanism, a decision was taken to use immunomodulatory and antiviral drugs, such as interferon alpha-2 human recombinant in combination with diphenhydramide, aminobenzoic acid, and sodium deoxyribonucleate. All these drugs have antiviral activity. They were administered in installations 3 to 4 times a day until the clinical picture comes back to normal. During the pandemic, only individually signed vials of eye drops should be used. The pathogenetic manifestations in the acute period of disease can be divided into 2 types. First, vasculitis, such as conjunctival vasculitis and retinal vasculitis, and thrombosis of CBS, CRV occlusion, and cavernous sinus thrombosis. These are the pathologies we had to deal with in real practice. As for ophthalmological manifestations due to treatment, this slide shows the main directions of therapy for COVID-19 used at the very start of the epidemic outbreak. At the very start, we focused on using remdesivir, favipiravir, hydroxychloroquine, lopinavir, ritonavir, and these are quite serious drugs, no-nonsense drugs that can cause a lot of side effects and adverse effects. And the long-term use of such drugs, of course, will have an impact on your eyes. Also, there were complications of the medical treatment, and these are the complications written into the package insertion, such as decreased visual acuity, violation of accommodation, corneal edema, keratopathy, scotoma, photophobia, risk of developing retinopathy, optic nerve atrophy. So you can see these are quite severe adverse events that can happen due to the intake of these strong drugs. Well, the pathology of the ocular surface due to treatment, and we encountered such cases in the red zone, first and foremost boiled down to allergic conjunctivitis. It started on day 3 or 4 of the disease, and it had a characteristic clinical picture. At the same time, we should say that during the peak of the pandemic in May and June 2020, and allergic conjunctivitis occurred in a group of patients which had allergy in their history. We cannot say right now whether it was the activation of the process or maybe it's because allergic conjunctivitis occurred due to the treatment or due to the infection. Recurrent corneal erosion was reported in several patients due to the treatment by remdesivir. The condition of the eye returned to normal, again due to specialized ophthalmic treatment to treat the recurrent corneal erosion, but at the same time we had to cancel remdesivir, favipiravir. After their cancellation, the corneal condition improved significantly. As for the treatment of the eye surface pathologies of allergic conjunctivitis, well, here you can see the classical scheme. Instillation by dexamethasone 2 to 4 times a day, instillations by artificial tear, such as heparin, and immunotropic drugs 3 times a day. As for recurrent corneal erosion, glucocorticosteroids were used, but in low concentration, 0.01%. Also, drugs containing heparin were added, such as drops and ointment and immunotropic drugs as well. As for the defects of care, unfortunately, we witnessed a large group of patients who were on ventilation, and after resuscitation measures, these patients had trophic keratitis and trophic corneal ulcer. There were quite a lot of patients like that. The treatment of this pathology is shown here: keratoprotective therapy, heparin-containing drugs, mostly in drops or ointment, antiseptic therapy, and anti-inflammatory therapy by dexamethasone 0.01%, 2 to 4 times a day. This slide, yours truly, is depicted here using PPE, personal protective equipment, when I walked in the red zone, and these clothes are not easy to wear. Well, this PPE is difficult to wear, but people get used to everything. And now I'd like to draw your attention to what I encountered personally when I worked in the red zone. We had a lot of patients with blepharitis and stye. That's the first manifestation. the first exacerbation. Before that, patients had no blepharitis or STI. There was an increased number of patients with scleritis. That was also the first manifestation. There was a drop in the number of patients with adenoviral ophthalmic infection, but this is due to the fact, and that's my personal opinion, that a lot of attention was paid to personal hygiene, well, treatment of medical equipment, instruments, maintaining the special protection equipment such as masks. That is why ophthalmic infection in terms of cases dropped this year and in the fall. Now the number of patients with herpetic keratitis and corneal ulcers remained the same.
As to the treatment of blepharitis and STI, well, actually, in this case, it really is very convenient to combine eye drops, glucocorticosteroids, and antibacterial drugs as Congenital, for instance. We take 2 drops 3 times a day for 10 or 14 days. If necessary, we added non-steroid anti-inflammatory drugs, Broxinux, in instillations once a day. And as a coverage of the toxic impact of the drug, we used artificial tear in installation. Also, we treated the skin of the eyelids with combined eye ointments, including glucocorticosteroids and antibacterial drugs 3 times a day. Later manifestations of the disease, I believe this is the category we will revisit multiple times in the future. But here are some things we can pay attention to right now as several months have gone by. Our patients report decreased visual acuity, a violation of accommodation, decreased tear production, scotoma, photophobia. They complain of the development of retinopathy. In COVID-19, the ophthalmic manifestations are not that frequent. However, at later stages, it may well be the case that they develop additional symptoms we will have to pay attention to. The SARS-CoV-2 genome during morphohistological examinations was identified in the conjunctiva, in the epithelial and endothelial cells of the cornea, and in the vitreous body. These data are of interest in terms of ensuring safety of surgical activities, in particular when you do corneal transplantation, for both the patients and the surgeon's safety. In conclusion, I would like to note that in spite of the fact that COVID-19 pandemic is quite long, the information on the course of the disease is quite diverse still. Conjunctivitis is not one of the symptoms that are part of the complex disease. At the same time, the presence of conjunctivitis should really put the doctors on alert in detecting COVID-19, both in patients diagnosed already with the disease and in those who are not diagnosed yet. Nevertheless, these patients should be taken as a risk group for conjunctivitis development. Although a positive RT-PCR result from conjunctival scraping is rare, it's important to deliver further research to determine the presence of genetic material of SARS-CoV-2. Now, in the complex non-specific topical therapy of diseases in the ocular surface in patients with COVID-19, along with this idiopathogenetic systemic treatments, we ought to use the eye drops containing heparin, immunotropic drugs, and glucocorticosteroids. When collecting the medical history in patients with inflammatory eye diseases, it is necessary to focus on the history of COVID, whether the patient has had it, and on the treatments delivered for COVID. It is necessary to also apply all the sanitary rules and instructions to deliver all the explanations in order to prevent the infection. On this slide here, I demonstrate the measures which we have split into the preventative measures to be taken at home. And actually, there is nothing difficult about that. These are just the standard measures that should be applied by all the patients in order to prevent themselves from contamination. and infection. At the same time, we also have the measures to be taken in an ophthalmological visit. I mean, these are the measures we have complied with for a very long time already, and everybody knows them extremely well, so there is nothing new I can share with you. Thank you very much for your attention.
Elena Vladimirovna, thank you very much for your remarks. And I want to say that your experience is extremely valuable. I think you should have the most number of the patients, I mean Russian patients. So thank you for sharing these ideas. Could you please put the next intro slide for next speaker? Dear colleagues, while we're putting on the intro slide, I want to say that you can write all your questions and we'll be glad to answer them at the end of our webinar. And now I want to welcome the head of the Department of Inflammatory Eye Diseases and Microsurgical Treatment of their consequences, Dr. Alexandra Zborovskaya. We know her name, we know her by face, we love to meet with her, even we do it not often, unfortunately. And I want to say that she's representing one of the most famous institutes in all former Soviet Union. And this is the State Institute of Eye Diseases and Tissue Therapy named after Filatov. There's a lot of great scientists are coming from this institute. And of course, her expertise is one of the best in our ophthalmological world. Alexandra Vladimirovna, please, your turn.
Yeah, Alexander, the floor is yours.
Добрый день, глубоко уважаемые коллеги. Меня нормально слышно?
Dear colleagues, can you hear me?
Yes, fine.
Да, значит, хочу немножко сдвинуться в сторону ковида, но в конце...
Okay, well, actually, I would like to talk a little about COVID. At the end of my presentation, I will naturally come back to it. So by word of introduction, I would like to start with saying that, in my opinion, we will have to add to torch abbreviation, yet one more letter. In fact, I believe COVID is yet another torch infection. So let me share with you a few words, and whatever is new is nothing but the well-forgotten old stuff. So what is torch infection? It's toxoplasma. It's other infections. For O and COVID, I believe, could well be added to the other infections group. It's rubella, cytomegalovirus, and herpes simplex. Torch infections are, in fact, a complex of infections that can cause neonatal diseases. We all extremely well know that they are now talking about there being a possibility of COVID affecting pregnant women, or how COVID can be transmitted in a transplacental fashion, and many other things are debatable now also. They are discussing these days that the course of COVID infection may be quite different in a pediatric and adult patient. The relevance of torch infection is very high. You know, it's responsible for 50% of infertility. It's the usual miscarriage. It's the developmental retardations or delays, congenital anomalies, and other things. So as to lab diagnostics, I understand, or I believe rather, that most ophthalmologists believe the outstanding diagnostic value of all the lab methods of diagnostics. Nevertheless, especially in the light of the COVID infection, I would like to note the following. The titers of antibodies are determined by IFA. In fact, and their level depend on how active the immune system is. So in a patient who has a suppressed immunity, it can be a congenital or acquired suppression of the immune system. It can also be caused by the history of COVID. The titers of antibodies in this patient can very well change. That is, in AIDS patients with toxoplasma-induced encephalitis will come up with excellent antibody titers to toxoplasma. As to PCR, Unfortunately, the likelihood of false positives in PCR is about 30%, and everybody has already encountered this in determining diagnosing the COVID infection. Also, I need to note that when uveitis are diagnosed, it is an open question. We still think about the following. I mean, there are the data showing that patients with TB-induced uveitis and with the tuberculoma in their ocular fundus, the PCR of intraocular liquid to TB will be negative. And in fact, the likelihood of that is at least 50%. So let me yet again draw your attention to the fact that the lab assays and the antibody titers and PCR are just an orienteer in diagnostics. Now, toxoplasmosis, of which we have a lot these days, was in fact discovered quite a long time ago, in 1908. We've been living with it for a much longer time than just since 1908. In humans, the toxoplasmosis infection goes regardless of the reproductive system. In animals, it's gender linked, so many animals are the vectors of toxoplasmosis. In fact, there is the primary infection through the gastrointestinal tract. If it is an adult, it's asymptomatic in about 90% of cases, but if it is an immune suppressed person, it's pneumonia, myocarditis, it's necrotizing encephalitis. And in congenital toxoplasmosis, they get infected through the vaginal secretion or through placenta. In congenital toxoplasmosis, you have hydrocephaly, microphthalm, and horoerythema. So you all know what an eye fundus is like in congenital toxoplasmosis. So what I like in toxoplasmosis is that it is a necrotizing lesion, but at the same time, pathomorphologically speaking, it's a granulomatous inflammation. It's a very interesting parasite. And in fact, I just want to note the following. Today, a toxoplasmosis infection we have in more than 90% of adult population in Western Europe, and the latest data shows that it's almost 100%. At the age of under 5, the primary infection takes place, which is compatible with the infection of herpes simplex. Acute toxoplasmosis can have a course that's very similar to an acute respiratory infection, like I demonstrate here in my slide. Congenital toxoplasmosis may be asymptomatic in 67% of cases, or it can manifest itself as a classic form of congenital toxoplasmosis. The ocular manifestations are extremely well known to everyone. In my experience today, we have a lot of comorbidities, that is toxoplasmosis, TB-induced chororetinitis. When you have a patient treated for toxoplasmosis, he is followed up for toxoplasmosis for several years, maybe 10 years or so, but then later you see the addition of the TB-induced processes in this patient, which really interferes a lot with setting the diagnosis. And it significantly aggravates the further course of the disease because it slows down the selection of the treatment mode. So we get a worse outcome. As to the examination, all the possible examinations are listed here for pediatric patients. As to the treatment, well, at least in my country, in the Ukraine, we use pyrimicin because we have no other combinations available. So we do the treatment they apply for pregnant women with toxoplasmosis in the US and in Europe, that is with pyrimicin. Dexamethasone, whether or not we should use it, well, this is an open question. In fact, I would like to share my experience. Right now, there is a trend towards uncontrolled usage of Azordex, that is intravitreal implants that contain glucocorticoids. In fact, we get some extremely negative outcomes when these implants used without a particular prescription, without a specific toxoplasmosis therapy. If you're not sure it's a pure autoimmune process, it's much better to not to use glucocorticoids without a specific therapy, let alone the intravitreal implants. The scheme of treatment is quite well known. In Brazil, for instance, where toxoplasmosis is a major issue and they have lots of visceral versions of toxoplasmosis there, the dosage may be different somewhat. In fact, they use bigger doses and for a longer period of time. If in this country it's maximum 4 weeks, our Brazilian colleagues say that the specific toxoplasmosis therapy can be applied for up to from 3 to 6 months. The treatment is as follows: steroids, an open question. And then also, well, we do not use systemic glucocorticoids. I've talked about the intravitreal implants. Laser coagulation, well, it's an exciting methodology to prevent relapses of toxoplasmosis-induced chororetinitis. I've used a laser coagulation. It does work. In fact, the relapse always happens at the brink, the border of the old lesion. So if you coagulate along the rim of the former scar, when you have a cyst rupture, the younger forms of toxoplasma do not get into the neighboring retina that is still alive, right? So it works as a methodology, as a prevention of relapses, although today we have very scarce publications about this methodology used for prevention. Today, the major source of toxoplasma is drinking water. So everything you see now on your screens, in fact, is a fact of life as well, but nevertheless, the drinking water is the main source of toxoplasma these days. Rubella, that's a very severe infection. There is no specific treatment to it. It's characterized by all tissue necrosis, and there is no inflammatory process, and systemic vasculitis, which in fact determines the issue with this pathology. It's neurosensory deafness in 58% of cases. It's heart disease and eye lesions. Diagnostics, well, there is no treatment. Corticosteroids are not indicated because there is no inflammation. So the condition is going to deteriorate. I want to note that a child with congenital rubella is a very active carrier of rubella until the age of 3. Until the age of 3, he can isolate the rubella virus into the environment. So he's got to be isolated for a very long time. And now one of my very favorite ones these days, it's CMV, known from 1904. Previously, they thought its incidence was determined by the social and economic status, by the cultural level, and the level of pediatric care. Nevertheless, however, these are some very new recent data. In France, almost 50% of the metropolis dwellers are infected with CMV. In North Africa, it's almost 100%. The global seropositivity in CMV is 86%. In the United States, it's from 69 to 87% of global positivity rate, and the data for Europe are used here. The risk group are the seronegative women. The term of infection is quite clear. My colleagues report that the main source of infection is children aged under 5, and the greatest risk group is pregnant women working as educators in kindergarten. Congenital cytomegalovirus infection, as you can see, is the cause of economic losses in the United States. It's $3 billion since 2015. In fact, you have this disease more frequently affecting African-American women. The white women are less frequently affected, and the Asian-American women are affected even less frequently than that. So there might be some strong genetic connection. Now, the disease affects the central nervous system, And in fact, cytomegalovirus, apart from rubella, is the major cause of sensory deafness. In perinatal infection, it might be also the cause of pneumonia and other CMV, as well as hepatitis and lymphadenopathy. CMV today is seen as the cause of the direct triad, pneumonia, hepatitis, retinitis, and encephalitis. It's the main viral infection after transplantation, and also it has indirect effects. That is, it reduces resistance to bacterial and fungal infections, it causes draft diseases, and delayed engraftments. Usually, CMV-induced retinitis is a peripheric lesion, so it's really difficult to monitor and follow children. Usually, they do not test the patients, be it pediatric or adult patients, for a broader pupil, so they leave out without attention the onsets of the infection. Well, in treatments, we have letalmavir, that's new since 2017. It's been allowed by FDA. Luckily, we now have valganciclovir with bio accessibility of 90%. And most excitingly, to date, no company has developed a vaccine that would make it to the third tier of clinical trials to prevent cytomegalovirus. Now, another issue of CMV is that you may have a relapse. That is, unfortunately, you don't have a sustainable immunity to cytomegalovirus. So a woman who's once had cytomegalovirus can well get a relapse of it or a repeat infection. Also, the density of population, that is, more frequently you have cytomegalovirus in the communities where you have more than 3 individuals living in the same room. Brazilian colleagues report that Brasilia is very much the case with this kind of dense population. I believe cytomegalovirus is no less interesting than COVID. It's just that we're used to it, and it does not seem to be as striking as COVID is in terms of its course. Nevertheless, I believe it is no less of a problem, if I may put it so, than COVID is herpetic infection. That is, it's the H in the TORCH abbreviation. Herpes affects the dermal tissue. It's neuroinvasive, neurotoxic. Naturally, it's latent. Also, it causes issues that are no less severe. It's quadriplegia, microcephaly, blindness in children. It's microphthalm and retinal dysplasia. If it is the virus 2 type, HSV2, it may cause the lesions of the eye, skin, and the mucous membrane. That's the SEM disease. It affects all the organs and system, and the infection usually takes place during the birthing process. Now, out of our favorite scenario now, I would like to focus on the following. Like Elena was saying, in fact, can only echo what she mentioned regarding how it all started. I don't want to repeat her words. It just happened overnight. However, ophthalmologists and anesthesiologists seem to be in the risk group as the community reports. For prevention, when an anesthesiologist does intubation, the surgical team should not be there in the surgery unit and should only step in into the operating ward in 10-15 minutes after the intubation has taken place. And these data are also confirmed by our Chinese colleagues. I mean, this is a preventative measure. Now, I remind you of this table because I treat patients with uveitis, and these days we have encountered particular features of monitoring and following up patients with uveitis, especially on immunosuppressive therapy. Now, these specificity of the course of diseases in these patients, especially given COVID-19. And there are special features of regarding the patients who've been primarily first time diagnosed with the autoimmune diagnosis after they've had the COVID-19. I mean, when we work on autoimmune uveitis, we're always taking many risks, but now essentially it's like ballet dancing on the brink because it's never been more unstable, right? Now, as to what I've talked about already, the pandemic of COVID is a substantial and unappreciated risk for pregnant women. And because the perinatal infections, in fact, are very threatening to the fetus. SARS-CoV-2 may well be transmitted to the fetus. Perinatal and postnatal infection or transmission routes are described frequently. To protect the newborns, you've got to instill the infectious disease control methodologies. Now, whether breast milk gets infected is still an open question, but very likely it does get infected. Possibly it doesn't, though. And also, we ought to think about vaccinating pregnant women. However, we ought to collect the material as we go, as our predecessors did. That is, we've come across the situation whereby, like, well-known infectious disease doctors, surgeons, and therapists worked until mid 20th century. That is, we can only monitor and follow our patients and treat them symptomatically. You know, in this decade, it's pretty much like what it was like back in history. We just follow up our patients and see what we can do. Now, as to those who treat uveitis, we rely on the consensus experience upgrades. The latest version is dated with 26th of March 2020. So when you have a patient on immunosuppressive therapy without clinical manifestations of COVID-19 or without a diagnosed COVID-19 infection, but with the manifestations, naturally, the hygiene and safety rules have to be observed all the time. Now, these patients should be received separately from other patients. In fact, they have to be waiting in their own reception. The patient should still be on systemic immunosuppression. You've got to control the level of white blood cells. The lower norm is 4,000 per microliter. The patient should continue the immunosuppressive therapy, and it's a must because many, in fact, pull out independently, and that's a very bad thing. If the patient is on immunosuppressive therapy and has a proven diagnosis of COVID-19, if the white blood cells level is less than 4 and the patient is asymptomatic, you continue the immunosuppressive therapy. Now, the patient develops the symptoms naturally, you progress to treat COVID-19. They recommend that the immunosuppressive therapy be stopped if there are clinical manifestations from tocilizumab, except for interferon and tocilizumab. As of March 2020, to treat COVID, they actively use dexamethasone. So in terms of using methylprednisolone, there should be no issue. Naturally, our Western colleagues are saying we should actively use parabulbar injections, but we never said no to them. In fact, that we should be more active in introducing non-steroid anti-inflammatory drugs in drops. My favorite Bronsonac naturally should come into play here. Again, we should not be too carried away by the intravitreal implants because, I mean, I've already shared my opinion on intravitreal implants with glucocorticosteroids. And in my personal experience, I would refer to the following: patients who are on systemic immunosuppressive therapy, methotrexate, prednisolone, as they formerly used more frequently, are responding in an easier way to COVID-19. I mean, their course is lighter. None of the patients has been to the resuscitation service, and none had their lungs significantly affected. However, we're now having the following issue. As I was preparing, I was online with my patients. We had a patient with severe granulomatous vaginaire with ophthalmological systemic manifestations. Before she learned she had vaginaire, she had had COVID. So we are now considering the dosage of pulse therapy. I mean, she should be receiving 1,000 milligrams of methylprednisolone, but I believe we'll go for 250 milligrams of methylprednisolone. So as never, colleagues, like truly never, our clinical thinking, our clinical experience, and our approach to the patients and our approach whereby we do not treat the disease, we treat the patient is extremely relevant as it has never been. It's never been more relevant than now. And it's outstanding we have scientists working with us and helping us.
Dear Alexandra Vladimirovna, thank you very much for such a valuable expertise. And of course, every word you're saying is really great. And thank you for sharing this experience. Dear colleagues, I remind you that you're able to ask questions. Just put them into a chat and we'll be able to answer it at the end of our meeting. Now it's my turn to speak about our let me try to put on my presentation. Okay. Now it's my turn to talk about ocular surface disorders in COVID-19 patients. So we do have a lot of experience by now. This is our institute on the picture, and this institute was not shut down during the lockdown. We were working, except we didn't have so many surgical cases, but we were still working. When I first met COVID patients, I was looking through literature and trying to find information, and that was approximately May, June of 2020. And there was not too much of information we could really find. Mostly it was all put on American Academy of Ophthalmology webpage, and it was only works from China. Nowadays, it's of course much more data on this kind of patients, but what I want to state from all this, I would not go through all of these papers. I would try to give the whole idea. The whole idea of all the papers is there is about 1% of patients who are suffering from conjunctivitis with a proven COVID-19. And all these patients did have a virus found in tears. None of them described, all of them were described as conjunctivitis. None of them were described as episcleritis or any kind of more severe diseases. Nowadays, we do have experience with harder conditions of the patients with some problems on the retina after COVID, but it was mostly toxical allergical problems. So I want to share our experience, and now having a lot of patients like this, I want to state that there is two types of clinical presentation for COVID-19 patients. The type 1 is toxicallergic acute follicular conjunctivitis, which occurs right during the COVID infection. Usually it's about 5th or maybe 7th day of infection when it starts. And there is a type 2 conjunctivitis. It's the worsening of chronic allergic conjunctivitis. So it's something what both of our speakers were talking before, because this is patients who didn't suffer too much during the COVID itself. They're referring to our clinic, and they're coming to our clinics in 2, 3, 4, even sometimes in 2 months, 3, 4 weeks, or even sometimes in 2 months after they're already cured from COVID-19. This was the first patient we received. This is not my data. This is the data of a doctor from St. Petersburg. And those times we were not seeing patients, so all we had is just a telemedicine, or maybe it's best way of telemedicine when patient is making pictures on a phone and then sending it to a doctor. And this is why we don't have such a good quality of a picture. But what we could see, this is the 6th day of the disease. The patient was not suffering too much of general COVID problems. He didn't have any problems with his lungs. He had only for 2 days, he had temperature of 36, 8, 37, so it was not anything bad. But the main problem he had was hyperemia and acute follicular reaction. And this is the first thing we saw in this patient. It was fluctena. It's a papilla formation on the bulbar conjunctiva. I have been seeing those before, but mostly it was in a very strongly allergic patients. Another patient came to us in mid-May. That was the first patient who actually entered institute, entered ophthalmological for ophthalmological help. And of course, we were scared at those times. We didn't know how to manage those cases. And again, you see the same problem. There is a episcleritis. And I wouldn't say that there was a conjunctivitis. There was no follicular reaction in this patient. That was episcleritis, again with fluctena. That was the 7th day of disease. Nowadays, we have about 20 patients like this. All of those patients were coming to us on the from 5th to 10th day of the disease. Some of them were just sending their photos, and all of them had a type of episcleritis. I would even state it by my own condition, because right now I'm recovering from COVID, and this is my eye about 3 weeks ago, and I did have a kind of episcleritis. I should say that I do not have dry eye, I do not have allergy. I do have sometimes conjunctivitis because of my work, but that was different. Usually it's conjunctivitis. This time it was a real episcleritis with a few papules, again on a bulbar conjunctiva. I did feel itching, I did feel swelling. That did bother me a lot, but then the interesting part, it really went away in a few days after I start therapy. I would be talking about the therapy later, but I want to say that most of these patients didn't have, even me myself, we didn't have a really hard time with COVID. It was going in a mild direction, and red eyes was something which did bother us. Differential diagnosis is, of course, mostly for adenoviral infection. Actually, when we first were receiving the patients with the COVID-19, we thought that it's a way of, we should treat it in a way of adenoviral infection. Later, we understood that it's a wrong idea, but at those times, of course, we didn't have any experience. So in next 3 slides, I would show you the symptoms which are specific for adenoviral infection, but not presenting in COVID-19. That would be the best differential diagnosis. First of all, it's acute edema of bulbar conjunctiva on first days. This is my old picture. I'm presenting this picture for maybe already 10 years, and we never see such edema in COVID patients. But we often do see it on the first days of adenoviral infection. Another thing is follicular reaction only on lower lid conjunctiva. For COVID patients, mostly what we see is involvement of bulbar conjunctiva, not only follicular reaction in lower lid conjunctiva. That could be counted as type 2 COVID-19 conjunctivitis, but I will be speaking about it a little bit later. Another symptom is hemorrhages. Hemorrhages are more specific for Coxsackie virus, and I think nowadays in season 2019-2020 we do have in Russia a lot of Coxsackie virus. I even went through papers and found that Coxsackie virus could be affected, could be eliminated, could be affected by COVID-19, and it actually exaggerate the hemorrhages in Coxsackie virus. So hemorrhages are not COVID-19. Corneal infiltrates had never been seen in COVID patients. At least in my patients, I didn't see anything like this. Another thing is, which is not presented, is pseudomembranes, which could lead to severe fibrosis, never seen in COVID-19 patients. Talking about adenoviral conjunctivitis in season 2019-2020, I would even say not only 2019, but it started at 2017 and then goes to 2020. There is a high incidence of pseudomembranes. 1 out of 300 patients does has pseudomembranes. They look like this before we take them off, and this is the picture after we remove pseudomembranes. So we had to remove them every 3 days. Why do we always remove them? I know that a lot of doctors are not touching pseudomembranes, but we had a study, a 3-year survey study. It included 24 medical centers and 2,400 patients with pseudomembranes, and we found that in 2.1% cases of pseudomembranes in adenoviral patients, they do lead to severe fibrosis. It's a huge number of patients. We don't want to see these patients on the street or meet them later if we wouldn't remove them. Even you see these interesting pictures we have. It's not only lesions, it's not only fibrosis on a lower lid, like in these pictures, it's fibrosis on an upper lid. This is not an upside down slide. And if it's easy to do surgery on this kind of patients, it's really impossible to do any kind of surgery, and there is no help for this particular patient with fibrosis in the conjunctiva of an upper lid. We cannot do too much, and of course, artificial tears doesn't help this patient too much. So just please pay attention to pseudomembranes and do remove them. Going back to our COVID-19 conjunctivitis, this is a patient from my first slide, our first patient with COVID. And at those times, we were not aware what to use for him. And only the activity of the doctor who was treating him brought us the idea to use corticosteroid together with antibiotic. So for Russian market, we would suggest to use Combinil. It's a combination ciprofloxacin and dexamethasone 4 times per day for 7 days. In India, of course, you're more lucky because you do have moxifloxacin plus dexamethasone, which is, of course, more advanced antibiotic. And I hope that at some point we will receive from company Centis this kind of drug. It's Kitmox DX. It should be used 4 times a day for 5 or 7 days. In Russia, we are lucky. We do have interferon eye drops, and we do use them since we're talking about viral infection. But again, Russian interferon has an anti-allergic component in it, so it really helps to deal with toxic allergic reaction. So in Russia, we would use Combinil and interferon 4 times a day for Combinil, 6 times a day for interferon. And now you would see what happens. In the 5 days, we have a full recovery of a patient. Nothing even shows the idea that there was some problem with eyes. I tried it on many patients by now. I tried it on myself. I was using Combinil myself. I was using it 4 times a day only for 3 days, and in 3 days, everything went away. So, so fortunately, it doesn't seem to be a problem. So what did we learn by now about COVID-19 conjunctivitis? All the symptoms reveals really fast. In 3-5 days from the therapy start, everything is fine. The therapy is based on corticosteroid usage. Even we are adding antibiotic, but mostly it's for elimination of concomitant bacterial disease. But the main idea is to use corticosteroid. And what we found in our cases, there are no damage to the cornea. Of course, we are not talking about severe conditions of COVID-19 when we are talking about patients who are under lung ventilation. Of course, in those cases, there could be some damage to the cornea. But in patients who are walking, who are able to treat themselves, there is no damage. Now, I want to present you type 2 COVID-19 conjunctivitis. It's a clinical case. By now, we have about, I would say, 4 or maybe 40, maybe 50 patients like this. And now it's really helpful for us to get this idea how it happens, because now when the patient comes and says, I had a COVID 2 weeks ago, 3 weeks ago, it takes us only about 2 minutes to write the prescription, and then everything would be fine. And we know for sure that we would not see this patient anymore, because once he gets well, he doesn't really show us again. So this clinical case is about a young lady. She was suffering from COVID 3 weeks before, and the COVID was going really bad in her case, and she didn't pay attention to the eyes. Actually, the whole her family did have COVID, and all of them did have conjunctivitis. This is something interesting, because after the COVID was over, none of them did have any eye problems. Only her had this conjunctivitis, so she came to us and she was suffering for itching, for foreign body sensation, and you could see that there was a little bit of interest in bulbar conjunctiva, not too much, nothing as I showed you before in acute period of COVID-19. But she did have follicles on her lower lid and in her fornix. So these follicles, of course, for all of you, looks more like an allergic disease. She said that she never had allergy before, but once we were talking to her for a long time, and we found out that she did have some signs of allergic conjunctivitis maybe half a year before to the COVID. So we made a decision that the patient was diagnosed with allergic conjunctivitis, and the COVID-19 general symptoms were acute, and the patient just didn't pay attention to her eyes at those point. So this patient does have a worsening of chronic allergic conjunctivitis, and this idea was proven later in many patients. The only question when we're treating a patient like this is there a concomitant dry eye in this patient? The most easy answer is just to use a Schirmer test. Because once you put a Schirmer test, and based on the results of Schirmer test, we make the decision if we need to administer artificial tears or not. It's extremely simple. Schirmer is okay. Now we don't use artificial tears. If Schirmer is less than 10 millimeters, we do add artificial tears. If the artificial tears are necessary, the best choice, I would say, in the condition of acute inflammation, as we have in this patient, is to use something very simple, and preferably with low viscosity, and preferably without any kind of conservant, which a detergent which is not good for allergy. So if you're talking about Indian market, on tears would be fine. If you're talking about Russia, for the beginning, OPHTHALMOLOGICAL BK is just great, wonderful, and really solves the problem. So the therapy for our patient was the next. We did the Schirmer test. In our patient, it was 28 millimeters, so we thought that there is no sign of dry eye. And again, patient was receiving Convenil, ciprofloxacin plus dexamethasone 4 times a day for 7 days. And again, I envy Indian doctors who has moxifloxacin plus dexamethasone, Kitmox DX 4 times a day for 7 days. After 7 days, in Russia, we would suggest to use Visalergol, which is olopatadine, 1 time a day for 1, maybe 2 months. We're treating allergy. But since we're treating an acute allergy for Indian market, I would say we don't need to use for a long time anti-allergic drugs if we do have a light steroids. So we can go in Indian market with fluas, which is fluoromethalon 0.1%, 3 times a day for 10, maybe 14 days. This is a better solution than anti-allergic drug, but since we do not have in Russia light steroids, then we have to use anti-allergic drug, which is fine, which is okay, which is actually good for preventing another attacks of allergy. So both ways you would have a good idea. All the clinical cases were published in August 2020. We did put it on Scopus journal, so if you would really want to find it, it is somewhere on internet. And what I want to finish my presentation is how to deal with patients who look like COVID-19 patients, who does have conjunctivitis of unknown idea of where it comes from, and could be suspected as COVID-19 conjunctivitis. Like in this case, we're talking about allergy, but is it because of COVID-19 or is it because of any other idea of allergy? Or maybe in this case, we could say that, look, these hemorrhages could be some kind of superficial bulbar conjunctivitis, like I showed you as a first type of COVID-19 conjunctivitis. But of course, there is no proof that it's COVID-19. Well, in these cases, I would not go with steroids because in most of the cases, we have either allergy or we do have adenoviral infection. So in cases when COVID-19 is not proven by general physicians or by laboratory test, I would go with, in Russia, I would say Broxinac, which is non-steroidal anti-inflammatory drug 1 time a day. Of course, I will use levofloxacin Signicept as an antibiotic. It's the best one on the market, 4 times a day, and ophthalmoferon 6 times a day. It's a Russian interferon. For Indian market, again, you're luckier than we are. So you do have moxifloxacin plus ketorolac, which is Kitmox Kata-L, 4 times a day for 7 days is just perfect, and it will really do the work. After 7 or 10 days, in India, we could use fluoromethalon. Actually, the idea is that in 7-10 days, we would know what we are treating. And we would understand that it's either already treated adenoviral infection, or it's a light bacterial infection, which needs steroids at the end of the treatment. Or if it's allergy, then we do deal with allergic conjunctivitis. So in 7-10 days, we could really add some steroids. So fluoromethalon for India 3 times a day, 10 or 14 days. And in Russia, we have to use an old dexamethasone 3 times a day, 10 days. I hope actually that in a few months, scientists would come in Russia with fluoromethalon. At least they were saying that it's coming on our market. This is a picture of our institute right now. We do have snow, it's freezing. And in my conclusion, I want to say that fortunately, the COVID-19 conjunctivitis should be counted as an acute toxic allergic reaction with no severe damage to the eye. I hope this is a good news for all of us. Thank you for your attention, and I would be glad to answer the questions at the beginning, at the end of our webinar. Okay, now I want to introduce the speaker whom we were really waiting for a long time. And I want to really thank Dr. Quirish Mascati for coming and for organizing this seminar, because of course, in India, it's strange to introduce Dr. Quirish Mascati. He's the president of All Indian Ophthalmological Society in 2014-2015. Nowadays, he is the president of a Corneal Society of India. But for Indian doctors, I want to say that we do know his name very well in Russia. We don't know his name very well. We hear his name when we go to Europe. We always see him at ESRS meetings, at SOE meetings, and we're really glad that he's with us and he would be able to present his presentation. Dr. Mascati, you're welcome.
Thank you. Thank you, Dimitri. I really enjoyed your presentation and it was an eye-opener. You really showed so many lovely cases of COVID-19 conjunctivitis and showed without doubt that it's a toxico-allergic reaction. We don't see so many conjunctivitis patients in India with the COVID-19. Somehow we are not seeing as many as you're seeing. We are seeing less than your 1% that you talked about. We'll go on to my slides. Ruchi Saxena from Centis will share them. So I decided that we're talking about the COVID era. I should talk to you about keratoprosthesis or artificial cornea word. Why am I talking about keratoprosthesis in the COVID era? Next. You see, the topic is relevant today because due to COVID restrictions and fears all over the world, the eye donation movement has suffered a setback. Good quality donor tissue has become scarce. Hence, the author has not done any optical keratoplasties or lamellar keratoplasties since 9 months because our government clamped down on collecting eyes from home deaths and in hospital deaths because of the fear of contracting COVID. Our technicians were not going there and things like that. So we had hardly any optical grade tissue coming out for the last 8 or 9 months. It's only now, since the beginning of December, that we have started the collection again. So therefore, we had only poor quality cornea tissue available. I took the opportunity, then I had a waiting list of patients for Boston keratoprosthesis surgery because the Boston keratoprosthesis requires only poor quality tissue just as a tectonic for strength. So I could do that. I have also done Pintucci keratoprosthesis where a donor cornea is not required. So I use this time to reduce my waiting list of patients waiting for keratoprosthesis. Next. So there are many different types of K-Pro or keratoprosthesis in the market today. The ones most widely used are the Singh-Wurst champagne cork keratoprosthesis, which is sutured with stainless steel, like the picture on the top. Then there is the modified osteodonto keratoprosthesis of Falcinelli, which needs a canine tooth and which is very complex. I don't do this. And the Pintucci K-Pro with a Dacron mesh skirt haptic. So it's a cylinder of optical grade PMMA with a skirt of Dacron, which is like a cloth material. We now, after Pintucci expired, we call it the CMP K-Pro, standing for Chavan, who is the man who makes it for me. Mascati, that is my name, and the late Professor Pintucci, who taught me this procedure. And the Boston K-Pro or the Dolman K-Pro. So on the right side of the screen, you see the Pintucci K-Pro, which has got a buccal mucosa behind it, so it doesn't look very nice. And on the lower part, you see the Dolman or the Boston K-Pro, which looks pretty good. Next. So I have been doing these two types. So let's go to some of the questions that will come to mind. Should every opaque cornea be offered a K-Pro? The answer is no. Corneal transplants give very good results in a majority of cases. You can see the top picture, that's 25 years after a keratoplasty and patient is doing very well, very clear graft. In infective keratitis, like a infection, bad corneal abscess, only a natural cornea will save the eye. You can't put an artificial cornea there, it will get extruded. And successful corneal transplants have a much better field of vision than K-Pros, like a natural field of vision. While a K-Pro will have only about 40 degrees if it's a Boston K-Pro and about 20 degrees if it's a Pintucci K-Pro. So it's fairly narrow field of vision. Next. So what are the indications for a Boston K-Pro? Boston is the easier one. I'll show you videos of both. So if there is any vascularized or a failed graft, or an opaque cornea with vascularization or with 360-degree stem cell deficiency, then you can't do a keratoplasty because it will fail because there's no stem cells. The eye should have good visual potential, no glaucomatous optic atrophy, with a normal posterior segment on B scan. An anterior segment should not be severely disfigured. And most important, there should be good tear secretion, good lid blinking, and good apposition of the lids. So the lids must be able to open and close well, and the tears should be fairly good, and the lid blinking should be good. Only then can you do a Boston K-Pro. Next. So therefore, which patients should not be referred for a Boston K-Pro? So those with poor tear secretion, as you see in the upper left, that almost very dry eye patient. So there, the Boston K-Pro will not do well. Or somebody who's got a keratinized cornea. The cornea again on the left, the same picture, the cornea is keratinized. So they won't do well. Or a history of previous corneal melts. As you can see in the upper right, the cornea is melted. So then it needs immunosuppressive agents. And the Boston K-Pro, because it requires a human cornea as well for support, it will melt. And those with poor lid blinks, like the picture below, his eyes are staring appearance and his lids can't open and close well. So then the tears won't spread evenly, and the natural cornea which houses the K-Pro will melt. Even the picture on the middle picture on the left, that young girl with acid burns all over the face, her lids were so badly scarred they couldn't close. So for her, you can't do a Boston K-Pro, you have to do a Pintucci K-Pro. Next. What are the contraindications for all K-Pros? So it's very important that the patient should be able to follow up with some eye doctor, because a lot of things can go wrong, a lot of complications can happen with K-Pros. So if the patient is staying far away from me, I don't mind. But the patient should have a good eye doctor near where he is staying, whom I can talk to on telephone or on internet and guide him in management. So if that is not there, or is unwilling to go to a local doctor near him, or I don't find a competent local eye doctor, I will not do a K-Pro. Then patients who are unable to understand the importance of compliance to treatment regime. So it's a lifetime treatment. Unlike a cataract, where after 1 month you can stop all treatment, in a K-Pro he has to put medicine for life, and he has to come for follow-ups for lifetime. So if he doesn't understand, not intelligent enough to understand this, better not to do a K-Pro. And of course, because I'm in private practice, if the patient cannot afford my unreasonably high fees, then of course I will not do the K-Pro. Next. So let us see some of the results of the Boston K-Pro. They're very good. So the first picture on your left, upper left, is chemical burns before surgery. And the same patient in the middle upper picture is the same patient after a Boston K-Pro. They have a very large scleral lens put over there. Thank you, Dimitri. And this is post-op, similar patient with 6x6 vision. And lower left side, you can see the Boston K-Pro with the suture still inside. And then this is a patient in the middle who had an HIV positive patient who I did a Boston K-Pro. This is 1 day post-op, little hemorrhage around, but it doesn't look so bad cosmetically. And this is how a Boston K-Pro looks typically with the sutures removed. After a year or so, sometimes we remove the sutures, and it's nicely vascularized. The donor cornea is well vascularized. The more vascularized the donor cornea, the more wonderful it is, because then I know that it will not extrude. The Boston K-Pro will stay there. So unlike in a keratoplasty, where we don't like vascularization, in a Boston K-Pro, we love the vascularization coming in. Next. So patient evaluation, this is Dr. Tony Aldave who taught us how to do this in 2009. So I've been doing it for the last almost 12 years now. So visual acuity must have good visual acuity, at least perception and projection. And if the corneal opacity is very dense, if the nasal projection is good all the time, you can rule out end-stage glaucoma. Then intraocular pressure whenever possible. Evaluate the blink mechanism and the tears, as I told you, because you need good tears. You must find out whether the patient is phakic or pseudophakic or aphakic. You must make the patient, if he is phakic with a crystalline lens, we have to remove the lens. If the patient has got good pseudophakia with a PC IOL, then I don't disturb this. And if it's aphakia, we can leave it as aphakic. Then you must see the optic nerve cupping to see whether the macula is okay, if you can, with B scan and with OCT if possible. And you must do an A scan because we need to measure the axial length to, just like for IOL calculation, even for Boston K-Pro to calculate what power of lens is required, we need the axial length. Next. So these are the parts of the Boston K-Pro. It comes in individual parts, all sterile. So on the top part is a mushroom-shaped PMMA front part. It's like a mushroom with a stem and a cap on the top. This fits into the corneal graft. So we take a large corneal graft and we make a hole in the center and we put this mushroom-shaped PMMA through that hole so that it acts as a tectonic support. Behind the corneal graft, which we take donor cornea, we put a back plate which has got 16 holes in it to allow aqueous to nourish the cornea. And right below that is a titanium locking ring so that it locks the whole assembly in place. Next. Let's see this on a video. So ideal cases, again to repeat, one or more failed grafts with poor prognosis for further grafting. Vision should be less than 3/60 with similar poor vision in the other eye. So usually in the beginning, you must choose one-eyed patients. Now I'm doing patients where the other eye is 6/6 because I can almost promise them 6/6 or 6/9 in this eye and no end-stage glaucoma or retinal detachment and patient able to afford the cost, of course. Next. So this is my experience in Mumbai. I've done 50 cases since 2009. So I'm sharing my first patient, which I did because the patient had a divergent squint. So I said, perhaps he's amblyopic. Even if something goes wrong, nothing will happen. But to my surprise, even though it was an amblyopic eye, he got 6/12 post-op in spite of divergent squint. And this is the second patient, the pre-op, you can see vascularized corneal opacity. And she had a history of corneal melt. So Aldave told us not to do it, but she was one-eyed patient, other eye was optic atrophy. So we did this and she's maintaining post-op 6/18 in spite of melts. We're treating it with immunosuppressives from time to time, methotrexate. Next. So this is a video of the procedure. So this is a Fleringer ring. This is a failed corneal graft that you're seeing over here. We measure the size of the graft. I'll just show you how so we refine the graft out. Is usually a 9 millimeter graft which is taken. So an 8.5 millimeter recipient is punched and a 9 millimeter donor graft is punched over here. So this is the donor graft is kept on a sticky plate. So and a 3.5 millimeter hole is punched in the center so that to put it on that mushroom shaped area. So I put it on the mushroom front part. As you can see, I'm putting some visco. Then I'll put the back plate. This is the older version which had 8 holes. Now we make it with 16 holes. So this is the back plate being put onto the stem of the mushroom and pushed into place with an instrument called a pusher. And then a titanium ring is put into place and again pushed into place with the same pusher. So now this is the graft which is the well assembled and it is then put into a dish containing cortisol or MK medium. And here we are seeing the surgery in progress. So here this is a patient who had glaucoma as well as a total corneal opacity with vascularization. So I'm putting an Ahmed glaucoma valve inside first, suturing the Ahmed glaucoma valve into place and putting a piece of donor sclera on the exposed tube. And the tube is pushed into the, from the limbus. I close the conjunctiva now. Now I proceed to scrape the epithelium of the cornea and open the eye 360 degrees because there is anyways 360 degree stem cell deficiency. So you can separate the limbus away to show you the extent of the cornea, the limbus. I mark the center and then do a 8.5 millimeter trephination. Full thickness trephination is done. Initial part thickness and then I open it and make it full thickness. This is again just showing you again the procedure. marking it, and then so you can do it with a simple trephine. You can use Barron-Hesburg trephine, and this is again the front part, as you can see, of the in another patient, put on a sticky plate. Then the this is using a different trephine for trephination. So this is a 9 millimeter trephination. As I said, you can use a simple disposable trephine. You can use complicated trephines. Then I'm making a hole in the center of the. It's very important to make the hole right in the center so that you have equal amount of tissue everywhere. And the graft is about 0.5 millimeters more than the host tissue. So I put it on the stem, viscoelastic again, and now push this donor well into place. Now put this is the one with the 16 holes, as I told you. The back plate is called, with the 16 holes. And then the titanium ring will be put into place. So it's just pushed into place. Again, showing you another patient, how it's pushed into place. And this is the titanium ring, which has got a small opening over there so that it expands a little when you push it into place and clicks there. So it holds the whole assembly together. That's the assembly. So this won't come out now. It's on a sticky plate. So we just remove it and put it in a bowl. Then proceed with the patient's own eye. This is a Barron-Hesburg trephine here, but as I said, I'm just showing you different surgeries in different patients with different trephines. So this was the patient in whom I put the IMED glaucoma valve. We are removing this. Now I find the pupil is not very good, so I'm going to enlarge the pupil. So the IMED glaucoma valve, the tube is poking out too much, so I trim it a little. Then I do a pupilloplasty. I'm opening the pupil because we don't want the pupil to contract. We want enough light to go in. So I'm enlarging the pupil. And then the whole assembly is simply put over here and sutured just like you would suture a PK. So the rest of it is more like a tailoring job. A good skillful tailor could do this. Stitching. I normally take interrupted sutures. That's just a cover to protect the macula. And that's the end of the procedure. We remove that cover at the end of the procedure and put a 16 or 18 millimeter bandage contact lens, scleral lens, which is changed every 2 months. And this is how it looks. You bury the sutures. And this is the end of the procedure. Next slide. And we go on to the Pintucci keratoprosthesis. Time is a little short, so I'll just tell you this is the patient. I've been doing this since 1997. So I've done about 85 cases. This is a patient who had 6/9 in the only eye. So Pintucci is always done in only eye because it's done in 2 stages. Unlike the Boston Capro, which is done in a single stage. That is Professor Pintucci, who taught me the procedure from Rome, Italy. So this is a post-op patient with 6/9 vision, but didn't like the cosmetic appearance. She says, when I go out in public, people look at my eye. But I told her, ma'am, you were perception of light only vision earlier. Next slide. So 85 bilaterally blind Asian patients with accurate light perception and B-scan showing attached retina. That's all that you need. Next. So this is how it looks. The Pintucci, it's a cylinder of PMMA and there's a skirt of Dacron, which is like a cloth. You can see it on the upper right. That's how it looks. Actually, it comes as sterile package. And this is how it looks in the eye with the Pintucci PMMA cylinder poking out from there. The Dacron mesh is 0.6 millimeter thick. Next. This is what I've done in Malaysia. So patient had 18 previous surgeries. 18 previous surgeries with acid burns in the eye. He was a milk vendor and he got restoration of sight following the Pintucci in 2006. Next. That's how I looked in 2006. So in this Pintucci, the tear secretion is not required. Even in a bone dry eye, you can do it. And lid apposition is also not mandatory. It's just the patient should not have phthisis. The patient should have some perception of light vision, and you can go ahead in these cases. Next. This is the video of the surgery. It's about a 5-minute video. So in this, we first clamp the lower lip in the mouth, and we take a large piece of buccal mucosa from the lower lip, which has got, it's quite thick. We can thin it outside. So it's done under general anesthesia, usually. And once you take this buccal mucosa, why do we take buccal mucosa? Because most of these patients have got ankyloblepharon or severe symblepharon. So we need to make space. Otherwise, the two lids are all stuck to each other. So here I'm removing the buccal mucosa. It's quite a bloody surgery. And we stop the bleeding by using hydrogen peroxide. And then you can suture the buccal mucosa or you can leave it open. So see this patient with ankyloblepharon, eye is not opening. I can't get to open the eye even by pulling it apart. So I need to snip all the adhesions first over here. So I'm trying to snip the adhesions. And then I try and find the cornea, remove all the adhesions and find the cornea. And I find the 4 recti muscles because the recti muscles have got blood vessels going around them. So I suture this buccal mucosa inside the eye after marking the center of the cornea and putting a tenor nylon suture in the center of the cornea, because later on, 2 months later, I need to find the center. So these are the 4 recti muscles which have been held in threads, and the buccal mucosa, which is a free graft, is sutured to the fornices and to the 4 recti muscles, so that blood vessels will immediately flow into this buccal mucosa and it won't get shrunk or it won't melt away. So the patient cannot see anything after this stage 1 procedure. So in stage 1, we simply remove the adhesions and put the buccal mucosa there. And then we open the Pintucci keratoprosthesis from its sterile packaging and put it under the lower eyelid for 2 months, so as to allow blood vessels and fibrous tissue to grow into the dacron mesh. So this is the part of the, in the eye, we have finished the eye part. Now I'm going to open the lower lid. So this is the lower eyelid. We open the skin and orbicularis and put the Pintucci keratoprosthesis upside down under the orbicularis. So this is 2 cat's paw retractors, and this is how it's put with a special forceps under the orbicularis. So blood vessels and fibrous tissue will grow into that cloth dacron mesh and leave it there for 2 months. Suture it in 2 layers, polyglactin or vicryl sutures for the orbicularis and silk for the skin. 2 months later, I remove it from its place where it was kept. So I make an incision on the skin. I can feel the bump there and remove this Pintucci cylinder which was there. And the Pintucci, the dacron mesh is now filled with fibrous tissue and blood vessels. So I remove it from there. Here it's been removed. I clean it outside. This is the Pintucci removed. I clean it to expose the out. See, now it's cleaned well. So you can see the PMMA cylinder and the thick dacron mesh, which has now got blood vessels and fibrous tissue. Now we open the eye. The buccal mucosa, which was quite thick, is now become a little thin. Now I take a superior rectus suture and I reflect the flap of the buccal mucosa like we reflect a LASIK flap, only not so elegantly. And I'm making provision for doing tarsorrhaphy, medial and lateral, because the patient is going to have only tubular 20 degrees vision. So because it's a very bone dry eye, so I'm going to do a tarsorrhaphy. So here we are reflecting the buccal mucosa. This is in the second stage now, 2 months later. So buccal mucosa is reflected back. I find the center of the cornea. I trephine it 4 millimeters with a skin biopsy trephine. I make 3 radial cuts in the cornea at 12, 4 and 8 o'clock. I make 3 radial cuts. I'm going to remove the lens, crystalline lens of the eye intracapsularly. I'm going to remove all the iris tissue. So this is the iris tissue being pulled out and removed because we don't need any iris. I'm going to do a core vitrectomy also. So I'm pulling the iris out. I cut it in bits. I remove it. I am removing the intracapsular cataract extraction with a cryo. So youngsters may never have seen this method of cataract extraction. And then I suture, after doing a little bit of vitrectomy, I close the 3 incisions. I put the Pintucci back there. I close, suture it to the cornea and the sclera, put the buccal mucosa back, suture it to the conjunctiva, and then make a hole in the center. And this patient can see 6/9. Next. So the results were no improvement in vision in 12 patients, 3 feet to 20/60 in 64. So majority of patients could see fairly okay. They could go to the toilet and eat their food, and 20/60 to 20/20 in 9 patients. So these are patients above is 5 years post-op, another is 10 years post-op. Next, lot of complications. So these are the complications: retroprosthetic membranes, extrusion of the K-pro, dropping of the K-pro in the vitreous, retinal detachment in 10 patients, and so on, phthisis in 10 patients. So almost every patient has got some complications. Some of them are blinding, some of them we can solve. Next. So these are some of the additional procedures I've done: retinal detachment surgery successfully in 10 patients, insertion of a second K-pro because one fell into the vitreous like a dropped IOL, and excision of pre-prosthetic membranes, and YAG capsulotomy, and vitrectomy for endophthalmitis. Next. In conclusion, though we see many more cases of bad chemical trauma as compared to cases of ocular surface disease and pemphigus in Dr. Pintucci's series, he had done 1200 cases. The Pintucci K-pro works quite satisfactorily in Asian eyes, and almost 65% of patients showed some improvement in visual acuity. Next. Next. To conclude, summary of my talk: though good quality donor corneas were not available due to COVID-19, the author, that is myself, made good use of poor grade corneal tissue to perform Boston keratoprosthesis during the COVID times. And I did a few Pintucci keratoprosthesis which require 2 stages and does not require human corneal tissue in this COVID period. I thank you so much for your attention. Thank you. You can stop screen share.
Dr. Mascati, thank you very much for your valuable surgeries, and I really congratulate you on such a great techniques. It's just wonderful. Thank you.
Thank you.
Actually, it's interesting. I would never thought that COVID-19 would affect surgery of this kind. It's really...
My numbers of keratoprosthesis increased because of this.
So it's good.
It's good. There's always some good to be made out. Yes.
Well, it's great that we have all this good news during our webinar. So now we can switch to the panel discussion. We do have a lot of questions. It's over 30. So I'll try to look through these questions and maybe choose a few of them. Just let me ask you, do you all have this question open, or you want me to tell them?
I think you can tell us.
So you don't have the question open?
I don't have the questions, yes.
Elena, Alexandra, what about you? If you would go to the last email from Fatima, there is a link to the questions. Did you find it, or should I just ask you?
Just go ahead. Just go ahead, Dimitri.
Okay, so I'll start with Dr. Yani. She was the first, and questions for her came a long time ago. The question was, Dr. Yanni, what is your recommendation for the treatment of patient with comorbidities of the eye, such as open-angle glaucoma after COVID-19?
Спасибо большое за вопрос. Глаукома.
Thank you very much for this question. So this glaucoma started before COVID, right? Or is it the result of COVID, which is very unlikely? Well, effectively, if the patient had glaucoma, all the therapy listed in my presentation, in fact, is going to be done in the same way, in the same amount, except for the prescription of dexamethasone. Dexamethasone is going to be limited. It's going to be provided either in a small concentration or it's going to be a one-time installation. All the other drugs go well with therapy in patients with glaucoma.
So we could use more anti-allergic drugs in this case? Or
Если имеется аллергическая
Well, if you
реакция,
have an allergic reaction, naturally you can. I mean, if it's conjunctivitis in COVID, the therapy line will be antiviral. If it's allergic conjunctivitis during COVID, the focus will be on anti-allergic drugs. If it's a bacterial complication or an inflammatory reaction like scleritis, we will either reinforce the antibacterial therapy or the anti-inflammatory therapy. So respectively, all these changes will be covered by hypotension drugs.
actually, I have another question which really goes together. It's an interesting question. Why do some ophthalmologists neglect the role of interferon in treatment of viral infection?
игнорирует.
Почему некоторые офтальмологи игнорируют роль
Why do some ophthalmologists neglect the role of interferon in treating viral diseases, especially in the Ukraine?
Это вопрос точно ко мне.
Are you sure this is a question to me? I don't ignore interferon.
Александр, может быть, вы ответите?
Alexander, would you like to answer?
Я могу сказать, что мы не игнорируем интерферон.
Well, actually, we don't ignore interferon in treating viral diseases, especially the primary segment of conjunctivitis. I always prescribe interferon in drops. This is not at all an issue, never.
Не знаю, откуда такие сведения об
I don't know where this comes from. No one ignores interferon in treating viral pathologies. No, thank you.
Okay, I don't know. Should I go back to English or should I stay in Russian? Well,
You can stick to Russian because the translator, interpreter is doing a great job in English. So you can stick to Russian.
Спасибо. В этой ситуации мне было бы чуть
Thank
удобнее.
you. Well, actually, it might be easier and more comfortable for me to speak in Russian because it's a particular kind of question.
Вопрос тоже от Елены Владимировны.
A question is to Elena.
При аденовирусном конъюнктивите
In adenoviral conjunctivitis, do you have to have dexamethasone or you can use anti-allergic drops? That's a very exciting question. In adenoviral conjunctivitis, we use both types of treatments, that is the allergic control drugs and the glucocorticosteroids. It all depends on the severity of the course and the manifestations of the clinical picture. If the patients have a very visible articulate course of conjunctivitis, if he has a history of allergic reactions, if the organism is susceptible to allergies, we will consider dexamethasone as a stronger anti-allergic drug. If the clinical picture is not very articulate, if the patient does not have any clear articulate allergic reactions locally where the conjunctiva is interested, you can use the non-allergy focused base drugs, like for instance, the ones containing fuselin, the vessel narrowing drugs, and that's quite all right if you use them. I mean, it's an acceptable therapy strategy.
Спасибо большое.
Thank you very much. My question will be to Alexandra. Thank you. Have you been able to open this? Oh, yes, absolutely. Right. So I can just send you the number of the question, right? Absolutely. I really like the question about, well, actually, I've lost the number. What is the planning and pregnancy monitoring tactics in the countries where the morbidity of torch infections is so high? Well, based on the data from the articles, the usual follow-up tactics are the same. A woman has to encounter torch infection. She's got to go through it and get the immunity to it. Next, before she plans her pregnancy, she gets tested for antibody titers. And if she has excellent IgG titers and she's immune competent, she can get pregnant and deliver a child, and her gestation will be fine. Because for a baby, what is dangerous is the primary infection of the woman during pregnancy.
Ее организм.
And in this case, the infectious agent will get through the placenta and will infect the child. If a woman had already toxoplasma cytomegalovirus or rubella or herpes, well, they got adapted to one another, and in case of pregnancy, even if there is a superinfection, the child will not have any problems. With cytomegalovirus, there might be problems, but that's the most optimal option. If there are no titers to IgG, in this case, there should be toxoplasma, rubella, cytomegalovirus, get infected with this, and then plan her pregnancy without any serious problems. Going back to this topic, here is another question from our geneticists. Did you see any cases of congenital cataract after cytomegalovirus infection? How are you going to manage such patients? Yes, there were cases like this, but unfortunately, these are patients who are referred to neuropathologists. So we should work with neuropathologists because that's a neurological pathology first and foremost. If a neuropathologist says, okay, we can interfere, then no problem, we can do a surgery procedure. So right now, congenital cataracts treatment or surgery is not a problem. At what age should we start? If neuropathologists well, allow us to do it, we can do it even before 1 year of age. Nadezhda Bobrova does this well in the pediatric department. Do we need any antiviral treatment before the procedure, before the surgery? If the child is not the carrier of cytomegalovirus, if the infectionists give us an okay, well, there is no need for specific antiviral treatment. So that's a multidisciplinary team, neuropathologists and infectionists, and of course, eye care specialists, ophthalmologists, all three of us. So it's not an ophthalmologist who makes a decision regarding the administration of the antiviral therapy. No, not the ophthalmologist, because therapy against cytomegalovirus, it's a very toxic therapy. And of course, we have a limited number of drugs. Foscarnet can be administered only at age of 12 and higher. So it's hard to find the proper drug in this case. And there is an interesting question from India. The risk of cytomegaloviral infection in patients with HIV infection. How high is the risk of cytomegalovirus infection? Well, that's the marker infection. If you can see cytomegalovirus retinitis, check the patient for the HIV infection. Well, in a case of AIDS, it's 100% of cases there will be cytomegalovirus retinitis. The frequency rate, if it's HIV infection, everything depends on the level of CD4+. The lower CD4+ is, well, the higher the probability of the disease. And the level of The monitoring duration depends on the level of CD4+. The lower CD4+ is, more tests should be done for the expanded pupil. Well, there is a question for you from Russia, from Petigorsk, Alexandra. Patients with mild COVID, when methylprednisolone is being taken, maybe Yelena can also answer this question after you. When methylprednisolone is used at 32 milligrams per day for 12 days, and there is allergic conjunctivitis and light retinopathy, what would be your recommendations to manage such patients? Well, I can say if the patient is on methylprednisolone, 32 milligrams, well, first of all, we should deal with which, well, 32 milligrams cannot be used to treat allergic conjunctivitis. Well, retinopathy is not caused by prednisolone, but with microthrombotic problems, lesions that occur in case of COVID-19, where we have more cases like this. Elena mentioned this in her presentation. These lesions are primarily due to microvascular problems, microthrombosis, and things like that. So that's not allergic conjunctivitis. So in this case, there is no need to interfere here. No, I think that's a different type of conjunctivitis, not allergic. Maybe that's the manifestation of the dry eye syndrome. That's more real in this case. Okay, Elena, what is your view? I think that as for this conjunctivitis, we need to clarify its etiology. If it were an allergic reaction due to 32 milligrams of prednisolone, well, due to the treatment, I think the manifestation would have been different, not just one response on the part of the conjunctiva. So naturally, the nature of conjunctivitis should be established. Maybe it's the dry eye syndrome, maybe the initial damage of cornea that leads to hyperemia. Well, I agree with you. I think that in this acute period, this maybe COVID-19 conjunctivitis, this term that we started to use now, maybe nothing should be done in this situation. Well, dexamethasone can be administered if possible. Any interesting questions you'd like to ask right now? Well, or maybe I will continue with the questions that were sent to our link. Okay, here is one question. It's not clear. Question number 17, no, not clear from what country, concerning, well, at least on my website, congenital toxoplasmosis, bilateral damage in ophthalmology, monolateral chorioretinitis. Yes, according to literary data, and in case of congenital toxoplasmosis, if it is accompanied by systemic lesions, usually it's a bilateral toxoplasmotic chorioretinitis. What we see monolateral cases, so that's good, it's so wonderful that it's not bilateral. At least a person has one eye through which he or she can see, because in case of toxoplasmosis, the scars are in the central part of the retina. But if the primary infection of the mother took place during pregnancy, in this case, yes, it's a bilateral toxoplasmotic chorioretinitis. And as a follow-up to this topic, you were quite aggressive, saying that the corticosteroids should not be used in such patients. And we have some experience of the use of corticosteroids in the long-term period. Well, it looks like we treated the patient and it looks like the inflammatory reaction is gone. Infectionists believe that there is no inflammation. Then we add corticosteroids. Fortunately, we did not have any failures, but Do you have any failures because you think it should this method should not be used? Well, I should say that Azurdex is used quite often without the long-term systemic anti-infection therapy. That's the first thing. Yes.
На сегодняшний день, вот я была на конгрессе в
Okay.
Тайване в 2019
As of today, and I was at the Congress in Taiwan in 2019, devoted to uveitis, and it was not me who mentioned this alone. Well, such effective drugs have the Janus effect, as we call it. They're effective, but at the same time, they can cause severe side effects. In my practice, there are 5 people after Azurdex. Well, we have only Azurdex registered for such patients, and I have 5 patients who had severe tubercular chorioretinitis with the damage to the posterior pole of the retina. They get systemic anti-TB therapy, but there are severe scars formed, and as of today, tubercular damage of eye is a serious problem, and not just in Ukraine. In India, I know, and we had a lot of doctors from India at that Taiwan Congress, and also the Ocular Tuberculosis Society is headed by the doctor from India. I forgot what the name is right now. I'm sorry about this. I don't remember the first and the last name of this doctor from India, but we have a lot of problems. And when we have a lot of tuberculosis, chorioretinitis with granulomas, big granulomas after Azurdex. So right now, in case of uveitis, using corticosteroids can be used, but they can be canceled anytime. No one can guarantee that the patient, for example, with Behçet's disease or with erythematosus, which is on immunosuppressants and who doesn't get enough systemic therapy, and we would like to enhance it by intravitreal implants. No one can guarantee that this person is not going to have the activation of toxoplasma, that there will be no activation of tuberculosis infection. They are in the risk group. I mean, those patients who are on systemic immunosuppressants by glucocorticoids or methotrexates, they are in the risk group in terms of tuberculosis activation and other touch infections, by the way. And if there is the activation of such an infection and there is Azodex in a human eye, well, it's a death warrant to this eye when there is tuberculosis chorioretinitis or severe toxoplasmotic chorioretinitis. And we cannot remove Azodex from the eye right now in this case. No one dared to do it. At least I've never seen such cases. That is why there is a trend towards giving up on implants with glucocorticoids. Glucocorticoids can be canceled at any moment, but you were also against prolonged corticosteroids. Well, not exactly. Subtenons, we can use them. We have a big problem with the diagnostics in patients with uveitis, and there is a law. If you are not 100% sure that this is a purely autoimmune process, so you should not administer glucocorticoids. Well, and there is a term that we use just in case we administer broad spectrum antibiotics, and this is justifiable in case of patients with uveitis. Please try to understand me correctly. It's better to be on ribamycin for 5 or 7 days here with paravalva dexamethasone instead of just a dexamethasone, and have the increase in the size of the lesion by a factor of 4. but we have to do. Those who deal with uveitis know about this. So we have to do something like that because, well, in case of uveitis, the diagnostic search can be for 3 or 4 weeks when you make a final diagnosis, and during this 4 or 3 week period, you can lose your eye. I'm not against intravitreal implants, but we should think clinically. We should turn on our clinical thinking before doing this. Well, Elena, do you deal with this? Well, such implants, well, I think that the use of such long-term things can be risky because there might be an uncontrollable situation for using such long-term implants. There should be specific indicators, and the risk of the development of uncontrolled situation after the introduction of such implants should be reduced to 0. I also agree with my colleague about the use of antibacterial drugs. Dr. Mascati?
Yes. Yes. Yes, can you hear me, Dimitri? Dimitri, can you hear me?
Yes, yes, I do.
Yes, yes. You are asking me something?
Do you have an opinion on that?
Yes, yes. As she mentioned, we do get a lot of cases of tubercular choroiditis, and we do give anti-tubercular treatment, and we are very reluctant to put Ozurdex inside because it can have a long-term effect and then you can't control it. So we prefer to just give anti-tubercular medicine and let the lesion subside slowly rather than bombard them with steroids.
Well, thank you very much. It seems that I'm the only one who is trying to promote Ozurdex for usage. But as I said, we don't have a big experience, and we do it only in a very, very late stages, in about a year or 2, when we do have proven then we don't have infection. And it's mostly, I was asking about toxoplasmosis, not tuberculosis.
Okay, okay,
I understand it is coming hand to hand.
Yes.
Так, я вернусь на русский тогда, если позволите.
Okay, I'll go back to Russian, if I may, and
почему-то несколько вопросов, причем
there are several questions here.
Скажи, есть ли какие-то особенности у COVID?
Are there any peculiarities of COVID-19
у пациентов с глаукомой?
In patients with glaucoma? What are the peculiarities of COVID-19 in patients with glaucoma?
Я могу только ответить,
well, I can
из всех наших пациентов
say that patients with glaucoma
пациенты с ковидом. Я не знаю, с чем это связано.
are very well treated, but we have a lot of patients with glaucoma and COVID, but it looks like there are patients like this, but not so many. So COVID-19 avoids patients with glaucoma. Elena, did you have cases like this? Yes, there were some cases with glaucoma with COVID-19, but I cannot tell you that there is a connection here between COVID-19 and glaucoma. Well, just patients with glaucoma. There are a lot of patients like that with just a glaucoma at our institute, and maybe they had COVID-19, some of them, but I don't think that glaucoma is the marker of COVID-19 disease.
May I add something? May I add something, Dimitri? In India, because we had lockdowns where the patients could not come to doctors. Many of the patients just stopped their glaucoma treatment on their own, or didn't come for follow-ups for 6 months at a stretch. So we lost some visual fields. Some visual fields became worse because the patients stopped their glaucoma treatment, thinking that it was, they were more worried about COVID and other things. So they didn't buy their eye drops from the local medical shops. So we had some patients where the glaucoma went down, became worse, not because of COVID, but because of the situation of the lockdown as we had in India.
У нас та же самая проблема с
We
пациентами.
have a similar problem here in Russia.
У пациентов с герпесом.
In patients with herpes, simple herpes virus. Can you hear me right now?
Yes.
It's not a question, it was just a comment. We have a similar problem in Russia in patients with simple herpes virus. Well, I liked the question from Professor Bahrdinova from Tashkent, Uzbekistan. Thank you for being with us. Besides ocular manifestations of COVID-19, do you have retina edema, retinitis, and other vascular lesions of the eye? Well, as for my experience, I didn't have any cases like this, but patients had complaints, but that was only online, that they had the problems with worsening of vision acuity, and there was a corneal edema, but everything was gone quite good. But there was also retinal edema, it seemed to me. And Professor Ioileva at our institute also talked about such cases, something like thrombosis, but that was the online counseling. And there were two cases of thrombosis, thrombotic-like cases, let's put it this way. And this picture is gone after 2 weeks, which is unnatural. You cannot just have a situation like this with thrombosis, that thrombosis is gone after 2 weeks. Well, so what is your experience concerning such things? Well, may I? Yes, okay, go ahead. Well, I'd like to say that we have had patients, well, a child with the optical nerve damage after COVID-19, but in general, right now, we have a high percentage of patients for whom neurological symptoms are number one in case of COVID-19, not lung damage, but the damage to the central nerve system with demyelinization in the brain and with manifested neurological symptoms such as the involvement of the central nervous system. And I think that we are already seeing the long-term consequences of COVID-19, and I think there will be more cases of neuritis, there will be more cases of other damages, not just the optic nerve damage, but other eye damages. So we should pay attention to all these issues, well, in the future. And why do you think so? And when there will be manifestations of such lesions? Well, I think the more manifested the signs of damage to the central nervous system, the more there will be such conditions like demyelinization in the gray matter of the brain, and obviously in this case the optical nerve will be affected somehow. It's quite natural from the point of view of pathophysiology. If there is a brain demyelinization, the optical nerve will be damaged to some extent. Well, the neurological symptoms will be more manifested. They will be monitored by neuropathologists, but I assume that after some time we will see a lot of cases of edema of optical nerves. I have already 4 patients with optical nerve edemas after COVID-19, and naturally we will also see the so-called thrombosis. I think the reasons for thrombosis will be different here, and also optical nerve atrophy in the long-term period, that there will be more cases like this, especially the descending nerves. Well, there are problems from the point of view of pathogenesis. In your practice, neuritis, did you have any regression here, or there was a neuritis and you couldn't treat it? Well, let's put it this way. eye acuity was increased to 1 2020. Well, let's put it this way, we managed to do it, but the field of vision, well, the patient doesn't care about the field of vision in this case, but the patient is more concerned about the vision acuity. What's the thickness of the retina in the macula, 300 or 400, it doesn't matter for the patient. The patient wants to see a 20/20 vision. He wants to read and write well. That's the main goal. Okay, so in our cases, these were quite they were conditions that could be reversed, the reversible conditions. Yes, at least now. Well, number one for us is like to assess the aggressiveness of COVID-19 is the interleukin level, fibrinogen level, and the dimers. Right, so we are thinking that an important role is being played by the response of the immune system to the causative agent. That is the involvement of autoimmune reactions such as cytokine storm, etc. That is why, well, we can expect that it's quite normal to say that the nerve tissue will be involved in, if we're talking about microthrombosis, it's quite possible. Well, for 2 weeks, we have a patient with thrombosis. I think it was a microthrombosis. Well, we are the only doctors who in patients with diabetes mellitus can see the vessels affected in this case. Ophthalmologists see such vessels affected in patients with diabetes mellitus. And this is also the same thing. We can examine those patients, and I think many patients with COVID-19, with severe COVID-19, if we could study the eye fundus, the ocular fundus, when they are on ventilators, when they get oxygen as part of therapy, we will see such pictures in a large number of patients. The only question is, it's impossible to do it right now using PPEs, using masks, etc. Well, it's impossible to do it. You should develop some methods of how to detect retinopathy, especially when we're talking about preterm babies. Well, Pentagon is used in such cases, right? Yes. Well, if we could do the same thing for patients with COVID-19 without just coming close to the patient, I think 80% of patients would have this particular picture, like optical nerve edema, microthrombosis of retinal vessels, something like that. Okay, here is a question from Ukraine and from Russian at the same time. Recommendations on the treatment of children with COVID-19 conjunctivitis, bringing to bear drugs that can be only administered to patients of certain age. There are certain limitations for patients. Well, dexamethasone would tell patients we cannot do without dexamethasone. If we can't use dexamethasone, we can administer Viselergol starting from the age of 6. Viselergol can be easily administered, but I should say that I've never had a patient younger than 14 years with COVID-19. I do not know, maybe it's just my case. Well, what about your cases? Did you have kids like that? We also had the older age groups. The youngest patient with COVID-19 was 18-year-old patient, but that was a patient with thrombosis. A young girl, by the way, and this thrombosis was formed very quickly. And what was the term? I think about a week after this, maybe 9 days after this, everything was normal after this treatment. As for patients with conjunctivitis, these were patients of the older age group, much more older, 35 years of age and older, even 50 and older. And when did this girl have this thrombosis? Well, when she was
где-то 10-й день
discharged from the inpatient hospital, day 10 plus 14 days of hospitalization. On day 24 from the onset of COVID-19, third week of the disease. So if she was in an inpatient hospital, she got anticoagulants. No, she was not on anticoagulants. That was the situation when anticoagulants were not the first choice drug. That's in early April. And can anticoagulants play a positive or negative role for such situation when there is edema of the retina? It can be positive and negative at the same time. We should weigh everything clearly. We should turn on our clinical thinking to choose this or that particular therapy. Okay, thank you so much. We're coming to an end. There are just questions concerning dry eye symptom, and there is a question from Russia about dry eye symptom. Schirmer's test is more informative. Normal test is more informative. Well, Schirmer's test is more informative, I think, and I think that right now we should turn on our clinical thinking. So Schirmer's test is more informative. Well, I think Schirmer's test is more informative, although our Western colleagues give up on Schirmer's test, and at the recent meeting of the Ophthalmological Society, Schirmer's test was not needed, they said at their meeting, but I and Alexandra were at a different meeting, and well, they said they disagreed with us. Schirmer's test should be used. Okay, I think Schirmer's test is more informative, and it's more informative for the patients. You can look at the strip and say, yes, there is a reduction, so the results of treatment are good. So Schirmer's test is more informative. All other tests can also be used. Colleagues, I do not see any more super interesting questions. Other questions are more or less the same that we have already mentioned. Do you have any questions? May I? Well, question concerning why heparin was used in local therapy, and what heparin drops did you use? What drops did you use together with heparin? So I'd like to mention about the pathogenesis and hemorrhages. Heparin has a positive impact on the eye surface. We have artificial tear with heparin, and also I think these two drugs are quite positive. They could deal with negative vascular problems.
Well, exactly. We also use heparin, and we see some very good outcomes. I'm sorry, I see another interesting question here, Dmitry. Does it make sense to use the drops of ophthalmophoron to prevent COVID to us doctors after seeing our patients? Well, that's an exciting one because we discuss it continuously in my family. My father, Igor Maichuk, uses it for himself and for his wife. He uses the ophthalmophoron drops twice a day. He's telling me he's feeling great. I tried using these drops during the worst wave of COVID, and it seemed to have worked out fine. I mean, the rest of the time I was using heparin, but I nevertheless got sick. So that was not a very strong protection, clearly. That's something to help our interferon, but not a great protection solution. Alexandra, do you have any other questions? Yes, I actually wanted to bring together two questions. One was why COVID belongs to the torch infections and what the scheme of therapy is. Well, we all want to include everything in the scheme of treatment, but the inflammatory eye diseases, especially uveitis, do not really fit into any scheme. Like human beings, a human being will never fit into any particular scheme if you treat a patient and not a disease. So it's not just my opinion that COVID will be seen as a torch infection. On my slide, I quoted some articles published in 2020. That was the articles by the infectious disease doctors. And based on the fact that we still do not understand the mechanism of the formation of the immunity against COVID, indeed, I believe SARS and COVID-2 will be considered the group of torch infections. Indeed, the ones that affect a woman, a fetus, and everyone, all humans. The whole different question is how our immunity is going to cope with this new type of viral infection. But, it seems to be handling toxoplasma, Epstein-Barr, herpes virus. So I believe SARS and COVID-2 will also be the next ones. Our immune system will find a way to interact with COVID. So I believe it really will belong to the torch infections.
Да. Ну да, конечно.
Well, yes, absolutely. Dr. Mascari.
Yes. Sorry, I didn't hear the question.
Do you have any questions which you looked through and they'll be...
No.
Well, in this case, we're coming to the end of our webinar. I really, really want to thank everybody who took part in it and to attended this webinar. And again, I want to say thanks not only to our opinion leaders, but to company Sentis, which is a host of our meeting today. And I want to pass the word to president of the company, Dr. Deepak Bari. We used to call you doctor because you're so close to our field. So, Dr. Deepak Bari.
So thank you very much, Dr. Dmitry Maychuk. It's been such a pleasure today to have all of you very important key opinion leaders with us and with our viewers who have learned a lot today by such different presentations, each one very relevant in today's scenario of COVID. And I'm sure that all the viewers have learned a lot of the latest information today. So I would like to once again thank all the viewers also for participating, the doctors and all our organizers who have done a wonderful job. And we look forward to the next webinar soon. Thank you very much once again, and good evening and good night, everybody.
Thank you.
Thank you.
Спасибо.
Thank you.
Profix is coming out with some card.
Okay, I think we're out of translation.